All right, our next two speakers are Kara Cover and Jodi Keller. Sounds like a good, sports team or something. Kara has worked for the Franklin County Public Health in Columbus, Ohio since 2014, and her colleague Jodi as the Associate Director of Healthcare System Preparedness. She oversees the systematic coordination of Central Ohio hospitals and community healthcare partners, emergency planning and response. Together, this is a real bonus. Together, they will discuss the regional response to the single largest botulism outbreak in recent history. Jodi and Kara, it's all yours.
Thank you. So not only a good sports team, but soon to be mother-in-law, daughter-in-law. I did that.
It was an arranged marriage.
It was an arranged marriage. Okay, who are the locals out here before we get started? Anybody local? So see us afterwards. We're looking for a good seafood place afterwards. So help us out, okay? Help a girl out here. Okay, so we're going to tell you a story today. It's going to be not like what you've heard already today. This is real-world event, and there are just so many good pieces to this story. And you're going to hear us say that, okay, this is another good piece to this story. So sit back and relax, stay awake. We're almost done. You get to go outside soon. So this is just, you saw some quotes earlier. This is one of my favorite quotes, that it wasn't raining when Noah built the ark. So that's why we prepare, right? We know the bad things coming. We may have been told the bad things coming. We know the threats are out there, but we have to be ready for whatever's coming. So this is what we're going to talk about. We're going to talk a little bit about Central Ohio and what we do for preparedness in our coalition there. We're going to talk about the response at Fairfield Medical Center on the week of this botulism outbreak. Kara's going to talk to you about the public health response and how that went. I'm going to come back and talk about the regional response and what we did. And then we're going to talk about the lessons that we learned and how things went sort of how we thought they were going to go, and how things didn't go at all how we thought they were going to go. So I'm employed by the Central Ohio Trauma System. We are a 501c3, and we are the regional coordination agency for the Central Ohio region. We have 15 counties in our region. There's 31 hospitals, 27 of those being acute care hospitals. We have 5, now 6, just a brand new trauma center in the last couple of weeks. 13 acute care, 7 critical access hospitals, and 6 specialty hospitals that are all part of our coalition. So our coalition on the hospital side started shortly after September 11th, right? We all had hospital coalitions back then. We didn't call it that, but that's what we had for the last, 20 years. But after about 7 years ago, ASPR decided, hey, we need to build these coalitions more beyond the hospitals. So we've started bringing those other partners in as well. We have, like what you heard this morning, our staff is on call 24/7. We call it the HIL, or the Hospital Incident Liaison. So there are 5 of us in our office that are on call 24/7 for the coalition, and we can be paged for really any kind of disaster or any kind of event. We get all kinds of pages. We get calls in the middle of the night, hey, do we have a tornado warning? Well, I don't know, I was sleeping. So you need to monitor your own weather. I don't know if there's a tornado warning. After September 11th, the HIL came about, and really it was those competing hospitals in Franklin County, which is Columbus, Ohio, go Bucks, where those competing hospitals decided we really can't do this alone. We can't manage a big event or a big disaster on our own. We need to coordinate our resources. We need to coordinate how we would respond and how we would accept patients. So the HIL was born after that, and it's written into all of our local, state, and regional plans. Like I said, we are on call 24/7. We coordinate the resources in the region, whether it's beds or ventilators or staff. We would help move staff around if we had to, but we also gather that information from not only our hospitals, but our coalition partners. So we're able to gather how many beds our long-term care facilities have available, so that if our hospitals need to offload patients into long-term care beds, we can do that because our hospitals can see that on our SharePoint website. We do situational awareness, so we're gathering the information from the hospitals and coalition partners. We're aggregating that data, putting it into a nice situation report that we share with the rest of the coalition. We share up to the state. We share it with the rest of the region. So the EMA directors have a good idea of what healthcare looks like in the central region. The state has a good idea of what healthcare looks like in the central region. But we're also sharing that information out with those coalition partners. And most of our partners never received any of that information before the last 5 years. They were out of the loop. They didn't receive any information. So what's it look like if somebody pages the Hill? So Hospital A gets hit by the tornado. You guys have hurricanes, we have tornadoes. Takes out Hospital A, they're no longer able to take care of patients and they need to evacuate. So they would page the Hill. We would send out a TENS alert, which is our mass notification system, and notify the rest of the hospitals in the region that Hospital A, no longer able to take care of patients. We need you to go into our system and put in how many beds you have available. They do that, then everybody's able to see that information. They can see it on our COHDIMS website. The Hospital A can see where the open beds are, so they don't have to call every hospital in the region to say, can you take my patients? Can you take my patients? How many beds do you have available? They can see it and they know where the open beds are, so they know where the appropriate beds are for their patients. Resource management works exactly the same. So if Hospital A now needs ventilators because they're having a botulism outbreak, they can page the Hill. We would put out a request to the rest of the hospitals, or we would mobilize our ventilator cache that we have on hand. We would also put out a request to the rest of the RHCs, or the regional coordinators in the state, asking them for ventilators or whatever resource that we're needing. And they would be able to mobilize those resources to Hospital A as well. If that's not possible, then we'd escalate it on up to the state and on up to the feds. So our COHDIMS website is what we use for situational awareness and information sharing. And on this, we're able to post continuous updates. The hospitals could all log on to the system. If we need them to do something additional, they can post. We'll post that there and have them do that. Any incident-related documents can be posted there. And then mutual aid resources and requests are also posted there or requested there. So this is just kind of what it looks like. The very first thing is how to page the Hill. So if you need us, the number's right there. You don't have to memorize it. It's right on the website. They would click on, as you see the blue box there, if we have an incident open, they click on that incident. It opens up to a brand new page, and then that's where they would put in their hospital resources, their hospital staff, how many beds they have open. We look at, is their command center open? Are they on generator power? Because those are always the things the governor wants to know, who's on generator power and how many dead people there are. So this is the statewide bed tracking system. It's called SurgeNet. You probably have something similar to this. But it's based on the NDMS category, so it's how many med-surg beds, how many ICU beds, how many pediatric beds are available. So the hospitals all go in there and they'll put in their bed numbers there. So looking at the botulism response then, I've given you the history of kind of what we do in the region. So this is into the meat and greet of this scenario. So Fairfield Medical Center is about 35 miles southeast of Columbus. It's the only hospital in Fairfield County. There are 220 beds, so not our smallest hospital, not our biggest hospital, kind of in the middle of the hospitals in the region. 30 ER beds, 16 ICU beds, and 15 step-down beds. So a little brief piece on foodborne botulism. It's caused by the toxin produced by Clostridium botulinum. The spores in that bacteria can be naturally occurring in the soil, and you can simply get it by not washing your vegetables well enough. So wash those potatoes before you bake them. And I should have started with this. You will never look at a church potluck the same after today, and you will never, ever look at potato salad the same after today. I should have started with that. So most outbreaks are really not from commercial food. that's not produced well, they're really from that canned food that's not been processed properly or washed properly before it got processed. So think twice about canning your food, too. So patient 1 arrived in the ED on Monday on April 20th, right around 8 o'clock at night. 6 o'clock at night, 7 o'clock, 8 o'clock. Military time was not my strength. They'd had dizziness, and don't ask me about that later. They'd had dizziness since 6:30 in the morning. And 4 o'clock, they had some speech disturbances. I actually did practice that time thing. I think I kind of got it right. They said that their tongue just wasn't working right, and their family said their voice sounded really muffled, and the drooping eyelids. So drooping eyelids was the consistent symptom that everybody presented with, and that was how they diagnosed the patients. Patient had a negative CT scan for stroke, because that was the first thing you think about with those presenting symptoms. The neurologist came in to consult on them, did the history, and during the history, she found out that he'd been out searching, hunting for mushrooms, wild mushrooms. So she thought, okay, this is an isolated case of botulism. So she contacted the CDC, had them send, requested that they send some antitoxin in for this patient because she thought this was one patient out eating bad mushrooms. Patient 2 arrived about an hour later. Nausea, vomiting, diarrhea, weakness, and lethargy, was slow to answer. This patient was a diabetic, but blood sugar was 63, so a little low, but not crazy low. And this patient also had chest pain. Patient 3 arrived the next morning. They still haven't put any of these pieces together that any of these patients are related yet. Patient 3 arrives the next afternoon. Nausea, difficulty speaking, blurred vision, alert but in severe respiratory distress, and with diminished breath sounds. This patient deteriorated very quickly, which most of the patients did. Within an hour, they could be awake, talking, the droopy eyelids, but an hour later, they were in severe respiratory distress and needed to be intubated. So they just deteriorated very, very quickly. This patient coded on the way to the ICU and died. So they started putting the pieces together after the third patient arrived, and they were taking this next patient up to the ICU, and the wife of the patient they were taking up to ICU looked into one of the other ICU rooms and saw a family member sitting there and waved at them and kind of acknowledged that they knew each other. And then the nurses were like, oh, do you know them? And they're like, oh, yeah, we go to the same church. And then they were like, okay, so have you eaten anything recently together? Oh, yeah, we had a church potluck on Sunday. Yikes. So they found out that all these patients had been to the same church potluck, and that's when the neurologist started putting the pieces together that maybe this is going to be bigger than just this one guy who was out hunting mushrooms. So really the diagnosis, like I said, was made just by those drooping eyelids, and they knew these patients were going to crash very quickly once they got in. Often the loved ones sitting beside the bed, so the husband may be intubated in the bed, and the wife sitting beside them, and the wife would start showing symptoms, and an hour later they were intubated. So they just would watch these people, just deteriorate very quickly over time. We're going to talk about the conference calls that we held in those first 2 days, but on the first conference call that we had the very first evening with the hospitals and CDC and the Ohio Department of Health, Fairfield relayed that there was a wife that was sitting there beside her husband, and it was the patient, the very first patient that came in, and they were watching her deteriorate. They just knew she was starting to show symptoms, and she was starting to get labored breath, and we need to take care of this. We need to transfer you out, because this hospital felt they could take care of maybe 3 intubated patients, right? It's not a big ICU. It's not, they don't have the skill set. So 3 they felt was their minimum intubated patients that they could take care of. And she was like, no, I'm not leaving him. You're not going to send me to another hospital. And they were just like, but you're getting worse. We can see it. By the time we were done with the conference call, she was intubated, and they said, we promise you that we'll keep you here. We won't send you to Columbus. We'll keep you here. And by the time we were done with the conference call, she was intubated and in the next bed. So, like I said, they just went down so very fast. So the situation report from Fairfield on that day one, the patient was diagnosed with botulism. They discovered that it was associated to the potluck, and they activated their Code Yellow, which is their disaster plan, around noon that day. CDC, ODH, which is the Ohio Department of Health, and Fairfield Department of Health were all involved. The media got wind of it very quickly, especially when you talk about a potluck. So the media was all involved. The church elders were able to provide a list of who all was at the potluck. So that was extremely helpful because they started making phone calls. Were you at the potluck? What did you eat? We really want you to come in. We really want you to come in and be evaluated. Well, I'm fine. Well, you might not be fine in 5 minutes. So please come in and let us evaluate you. So they were begging people to come in. And this is all being done at the hospital. And they started taking food histories. What did you eat? How much did you eat? And really, they found out that, I might be stealing some of your thunder here, but one bite of this potato salad was really all it took. The toxin was so high in this potato salad that it really only took one bite. They took one bite and they're like, "Ooh, this just doesn't taste right." But sweet little Aunt, Miss Emily made the potato salad, so we gotta eat it. But really, only one bite was enough to make them sick. So by 11 o'clock that night, 28 total patients had presented to the ER. 2 patients had been admitted. The 1 patient had expired. They had 5 patients that were intubated. 18 patients had been transferred out. So effectively, we were evacuating patients from Fairfield Medical Center, right? And 2 patients had been discharged from the ED. So they were evaluated in the emergency department, didn't have any symptoms, and they were sent home. Day 2, 12 more patients presented to the ER. They had 1 pediatric patient that we sent to Nationwide Children's Hospital. 4 doses of antitoxin were administered, and that first dose didn't get administered till 4:55 the next morning. And we're going to talk about the delivery of the antitoxin because that's a whole other part of the story. 2 patients had left AMA. Keep that in mind. We're going to come back to that. 4 patients had been admitted. 4 patients to the ICU in critical but stable condition. 6 patients in step-down and stable condition, but they were, watching them. They set up kind of this holding area for these patients because they were just afraid that if they sent them home, they might not make it back to the hospital. So they just kind of set up this little waiting area for them to kind of hang out. Day 3, 4 more patients came to the ER. 4 patients remained in ICU in critical but stable condition. They had 1 patient left in step down. They finally had confirmed botulism in stool samples. They were still doing the screening questions, getting food histories, discharge teaching. So this is the AMA patient. So in these phone calls, they were checking up on everybody, even if they didn't come to the emergency room, if they came and were discharged home because they didn't have symptoms, they continually called them a couple times a day to see if they were okay. So they were trying to get a hold of this gentleman who had been in the day before, had signed out against medical advice, and they couldn't reach him. And they contacted his wife, and she said, well, he was at home, he was mowing when I left, he was fine. So they weren't comfortable with that. They were like, okay, we're not okay with just not finding him. So the police chief from the medical center drove out to the house and found him unresponsive in the yard. So they were able to bring him into the hospital, get him intubated, get him transferred out. Keep in mind that this is a small community. They know each other. They're related. They go to church together. They just all know each other. So it was really hard for the hospital staff and all the church people to deal with this. Managing the patients was very difficult. These were not your normal ICU patients. It was very hard to keep them comfortable on the ventilators. They were very difficult to manage on the ventilators. They were conscious. They could hear you. They could understand what you were saying. They just couldn't communicate because of the paralysis that was the descending paralysis. They couldn't communicate. Some of them would be able to somehow communicate, whether if they were able to write, some of them were still able to write things, but their eyelids were so droopy, they couldn't keep their eyes open, so they would ask, please tape my eyelids open so I can see you. Okay, so that doesn't sound like fun either, right? So, that can be very painful if you get any corneal abrasions or anything on there, so, but they were very difficult to manage. So the summary for the response at Fairfield, a total of 53 patients were seen during the outbreak for those 7 days. They had 24 confirmed cases, including 1 death. The food source was the homemade potato salad from the canned potatoes. There was cross-contamination into the macaroni salad because the spoon got shared. Another thing to keep in mind when you go into the potlucks. And they gave a total of 9 vials of antitoxin at Fairfield Medical Center. So this is one of my favorite pictures. Actually, it's the only picture we have from the response. And this is kind of a good take-home lesson. So they knew that these patients were crashing and burning very quickly. So they thought, we need to have ambulances here to transport these patients out when they come in, because we want them out of our ER as quickly as we can get them out, right? So they pre-staged dozens and dozens of ambulances. These ambulances came from 4 counties away and stayed there for 5 days, just waiting for a trip out. So the hospital had to have communications with them. They had to coordinate that. And they had to feed them. I mean, they fed these guys because they were there for days. So some of the challenges, there was a limited number of critical care beds, which we'll talk about a little bit later, in the region. We already knew there was a limited number of critical care beds. The transfers were kind of a challenge for them because they would call the transfer centers at the larger hospitals, and every time they made a transfer request, they had to go through the whole scenario again. We've had this potluck, people ate bad potato salad, we need to transfer this patient, they need to have antitoxin, maybe they're intubated, maybe they're not. So all of that, they had to go through that every time they transferred a patient. And then the multi-agency coordination between the health department, EMA, and the hospital in the county. There were some challenges in getting that really established from the beginning. So lessons learned, they really felt that if they would have had that multi-agency coordination established at the beginning of the event, that things would have gone better throughout the whole thing. Fairfield Medical Center thought that CDC would come in and save the day. That was not the case. Actually, CDC was learning from Fairfield Medical Center. They sent us a what you should know about botulism form that was from 1971. That was, I'm not kidding you, mimeographed. That's how bad it was. Like, it wasn't even a typed sheet. And that's what we were supposed to be sharing with the patients. They really played a supportive role, and they really learned from what was going on in the region and what was going on at Fairfield Medical Center. The time frame to get the antitoxin was 18 hours after the request. 18 hours. Kara's going to talk more about that, but that's not what anybody expected, right? We all thought, we're going to call, it's going to be here in an hour, we're going to save these people. Antitoxin is not the cure. So this was the biggest take-home point from the whole entire week. Antitoxin is not the cure. Intubation is the cure. So antitoxin only decreases the paralysis, the progression of the paralysis. So if you get the antitoxin, it should stop the paralysis, and you should be able to, start to heal. I mean, it's going to take months and years to start to get back, if you ever get back to where you were before this event. But the antitoxin is not the cure, it's intubation. So that was the big take-home thing. Many people still tire easily. They still are in rehab. But it was just such a big event for this little community and really for our whole region. Okay, Kara's going to talk to you about the public health response.
Okay, so Jodi tells me that while I don't have nearly the number of slides she does, I have the best slides. So.
She does.
So a little bit about so while Jodi coordinates all the hospitals and all of that, I do coordinate all the health departments. So there are 17 health departments in our region, and so sometimes I joke that it's like herding cats. I have no authority or anything like that, but I'm just there to help coordinate them, and as well as with the situational awareness and all of that. And then I also am an epidemiologist. So I got called into this on both aspects as the regional coordinator, as well as providing some epi support to the region. So, as everybody knows, public health's bread and butter is to do case follow-up and contact tracing for reportable diseases. So one of the biggest goals was to identify, this was before we knew it was the potato salad, try and identify any additional cases, as well as identify the food source. We hadn't seen botulism in a very long time. Nobody really knew what to do with it. Thankfully, one of the health departments in the region did have a botulism questionnaire. So they were able to send that over, and it at least provided a starting place for the health department to use to ask some questions. Because nobody sees botulism, the questions were pretty generic, based on any past outbreaks that anybody had had. Have you eaten anything canned? Have you eaten, and it asked very specific, have you eaten any jalapenos? Because at one point there was an outbreak with jalapenos. So the key to this was all being very flexible. So as we went along, we modified this questionnaire, I don't know how many times. And so initially, the church elders that Jodi mentioned, they were fabulous. They were probably the best church, I don't know if they were pastors or what exactly their title was, that we could have asked for. So they had this potluck, and then they left town. They were going on vacation. And so when we called them and asked them for the church list, they were in another state at this point. So they turned around and they were driving home, and while they were driving back, they were creating a list of everybody who attended and all the foods that were brought. We had hoped that maybe there was a sign-up sheet that said specifically that they could just send us. No, we didn't get that lucky. They, though, thankfully sat down and thought of everything that everybody brought. They went through the list. Okay, what did this person bring? What did this person bring? And there were some people that were easy. Oh, Jodi, she always brings the carrot cake or whatever it was. But they literally had to create that list from scratch for us. So they did that while they were driving back. They also were key later on in terms of letting us get into their dumpster. But, so we start using this questionnaire and we start interviewing patients. Oh yeah, I ate potato salad. And that was one of the items on the list, was potato salad. Okay, cool. And then we found out that, there's two potato salads. There was the Kroger store-bought potato salad and then the homemade potato salad. Okay, so then we separate that. We have modify the questionnaire, have two potato salads. Oh wait, there's a third potato salad. There's the Kroger mustard potato salad, the regular home-style Kroger potato salad, and then the homemade potato salad. So the key to all this, as somebody mentioned earlier, is to be flexible, be able to just continue to go with the situation and the flow, and modify as you need. So lesson learned, don't ever think you got lucky, because we had a minute. Jodi and I discussed that, at least we got kind of lucky in this, that we had a very specified group of population. We knew exactly who was at the church. We knew exactly who was potentially exposed. This wasn't a commercial outbreak where, you don't know who all ate it. It wasn't at like a fair or something where there was a lot of people coming and going. We knew exactly who had been exposed. No, just kidding. We found out, Jodi and I got a phone call. It was like 6 o'clock at night. We found out that they had taken leftovers from this church potluck to a nursing home.
Told you it was a good story.
We all know that nursing homes, the people who are generally in there, aren't necessarily the healthiest population or, not the kind of people you want to get botulism. So we didn't know, though. Nobody could tell us. Did they take it home to take one plate home to the nursing home for a spouse of somebody? Did they take to the nursing home tables of leftovers? Nobody could tell us that. So we didn't know if the whole nursing home was exposed, just one or two people. Come to find out, it was just one or two people, and they were able to get it out of their room before they ate it. So thankfully, nobody from the nursing home ended up with botulism. But, so as Jodi mentioned a little bit with the personal connections, it was difficult to contact a lot of these potluck attendees. So, they were in the hospital visiting either with their loved ones, or they were in the hospital because they were sick. And if you're intubated, you can't really answer our questions on what food did you eat. Doesn't really work that way. And then if they weren't, even if it wasn't their relative, their spouse, or whoever that was in the hospital, this is a very close-knit community. And so they heard that their church members were sick and in the hospital, so they were visiting with them. And if you're in the hospital visiting somebody who's in the ICU and you get a phone call from a number you don't know, are you going to answer it? Probably not. So they had a lot of trouble getting in contact with these people. And then we had the personal connections. So they knew these people. The people at the health department knew who these people were. It was really hard for them to call and ask them a 20-minute interview when they knew that they wanted to be with their loved ones at the hospital, or that it was really hard for them to ask these questions. But those personal connections also worked in our favor. There were a lot of times you'd call somebody, Well, the number that we got at the health department was often whatever was listed with your insurance. So a lot of times that's like a home phone number that maybe you don't even have anymore, or it rings and nobody answers it, or you're not home, you're not necessarily going to get it. So sometimes people had personal connections that they knew these people's cell phone numbers, or they knew so-and-so's mom and she can tell me how to get a hold of her, or could send them a text and say, hey, the health department wants to talk to you, call this number. So it was a good and bad thing, the personal connections. So while all of the nursing staff was busy doing interviews and trying to figure out what was going on, environmental health was not left out either. They got the lovely job of going dumpster diving. So aside from the food that was taken home to the nursing home, there was not really any other food that was left over. And once the nursing home heard that this maybe had botulism, they got rid of that as fast as they could. So that wasn't an option for us to test either. So these church elders came to our rescue again, and they let us into the property and gave us access to their dumpster. Thankfully, the trash men had not yet come. I don't know what we would have done at that point. But these lovely sanitarians got to go dumpster diving and find trash bags that had leftover food in it and open it up and see what was in it and see if it was potluck food or not. Hopefully it wasn't like, I don't know, bathroom trash or other trash that nobody wants to play in. So in addition to like the macaroni salad or the macaroni and cheese having the spoon shared, some of our samples were also contaminated because it was coming from a dumpster. I mean, everything's getting blurred together. So that'll come up later, that some of our numbers don't show up as much as we'd like them to, but it's mostly due to cross-contamination. So the other thing is, so the individual who made this potato salad was one of the individuals who got sick as well. So she was in the hospital, and she was not doing real well. So the health department contacted her children, and they let us into her house. And her house, this isn't like, when you think of usually like a foodborne illness, like, oh, somebody had cross-contamination, they probably didn't wash a cutting board well enough. This woman's house was immaculate. What you would have thought everything would have been fine. Everything was clean, her counters were clean, everything. And they'll go downstairs to her basement and open up this pantry-type area, and she has shelves upon shelves of home canned goods. And they had to throw it all away. They didn't know, this is what this woman did. This is what, she was an elderly woman who came out of the Depression era, and they canned everything. And so they threw it all away because they didn't know if anything else was contaminated or if anything else was potentially at risk for her or anybody else that she may be feeding. So thankfully her children were really good about it, and she was good about it too. Nobody was angry at the health department for throwing away her food, but it was hard for them to do because they knew this was her livelihood as well. So the key to canning, not trying to scare anybody off from canning, just if it's low acid, make sure you use the pressure method, not just the hot water method. And then thankfully the Ohio Department of Health Laboratory was only about 45 minutes to an hour away from where this site was. So they were able to pack samples up as shown on the picture on the right and then drive them to the lab. So if anybody's into the numbers, here's the epi side of things. We did get assistance from CDC with their EIS officers, the Epidemiology Intelligence Service, as well as their epi aides. And then the state provided some support as well through their team. But in the end, we found out that if you had consumed any type of potato salad, you were almost 14 times as likely to have become ill with botulism than if you wouldn't have consumed potato salad. And then the homemade potato salad was only a 9.1 times as likely. But again, that comes from when we first started with that questionnaire, it just said potato salad. It didn't say what type of potato salad. Also, you have the people who don't know what type of potato salad. I don't know, I would be guilty of that. I ate somebody's potato salad. Oh, I don't know. So, this was the largest, you probably can't see that very well. This was the largest botulism outbreak in 38 years. So this slide shows you some of the other sources. Peppers, beans and potato salad, fried onions, baked potatoes, frozen canned chili. So all of those are things that were on that initial questionnaire, including the jalapeno one that I mentioned. But this was the largest outbreak since 1978, it looks like. And this does say that we had one death, and I believe Jodi talks about it a little later. This slide is a little outdated. In the end, we did have a second death that was a delayed death, but was attributed to this outbreak as well. So a little bit of myth versus truth. So again, Jodi talked about the antitoxin saves lives. It's really the ventilators. So we were really thinking that, got to rush to get that in here, save these people's lives. And that got repeated to us from the federal level, I don't know how many times, antitoxin doesn't save your life. We also thought that the antitoxin would be delivered to each hospital. Our plans, and nobody really had a plan for botulism, but with other things, either State Highway Patrol or other people would help deliver it to the hospital. That was not the case. And it was, along with the next one, that antitoxin could be pre-staged at a hospital. We knew these hospitals in Columbus were going to be receiving a lot of patients. So we were hoping we could divvy up the antitoxin and put, 5 or 6 doses here and a couple more doses at this hospital, and that was not allowed. By the state, we were not allowed to do that at all. So it all had to sit at the state warehouse, which is in Columbus, and then every time that we had, a hospital had a case of botulism that had gotten transferred to them or showed up there, they had to go through the procedure, talking with the state, making sure that they were allowed to provide that dose of antitoxin, and then it would be released to them. And they were expected, the hospital was expected to drive to the warehouse and pick it up, and then come back to the hospital and administer it. That was viewed as a huge burden on the hospitals. They didn't have time for it. They're supposed to be caring for the patients, not driving around Columbus, trying to find a warehouse they've never been to, and it is a very non-specific warehouse, so if you've never been there, you can easily drive by it. So the health department did end up doing that for them. We just transported it for them. The health department would get a call. We'd go pick it up and take it to the hospital so they could focus on caring for the patient. The antitoxin came from the SNS, and we were under the impression that it would all just show up. No, it all went to Atlanta. They packaged it all up together and then came to us in one shipment from Atlanta. So all the different places that the SNS is all sent their antitoxin to Atlanta before we finally got it. And then we thought, because it was so precious to us, we all needed the antitoxin, it'd be kind of special carrier or something. Nope, just came over the baggage claim like your and my luggage did, or our luggage did this week. Just nobody was with it. There was no chain of command. It just popped over the conveyor belt at the baggage claim. Anybody could have grabbed it, but I mean, really, what are you going to do with it? Nothing, other than treat a botulism patient. But to us, it was so critical. So that's just the antitoxin transport protocol, and then the regional response. So I know we talked about PIOs earlier. That was something that they ended up needing resources for. The PIOs, the media was coming from everywhere. So we did provide some resources from that regionally, as well as interviewers and epi support. And then we did health alerts and regional email alerts to people both inside and outside of the region.
All right. Can you believe that they didn't, like it was just checked luggage? I mean, that's a really good part of the story too. So talking about regional coordination. So on Friday, before this event even happened, we got a call from one of our trauma surgeons in Columbus and said, hey, we just got wind that there's not very many ICU beds available in Columbus. Can you guys do a bed count and let us know? So on Friday, we knew there were only 9 ICU beds in the entire city, and we have 12 hospitals. So they were all concerned that if we had this any kind of big event, not knowing there was going to be a big event, that there wouldn't be any ICU beds. So we again looked at that the next day, and we had about 30 ICU beds on Saturday. So everybody was a little more comfortable with that, but we were all already aware that there was a shortage of ICU beds in the city. So day one, Fairfield Medical Center paged the Hill about 12:45, told us that they had 3 clinically confirmed cases of botulism. They had 7 more people in the waiting room. This was anticipated to be this potluck thing, so they didn't know how many patients they were going to see. We activated the Hill to level 1, which is our full activation. We asked for beds from all the hospitals so that Fairfield would be able to see where the open beds were. We already knew that ODH and CDC were involved with requesting the antitoxin coming, and again, at this point, we're thinking we need this stuff in these patients like now, not knowing that it really isn't the thing that saves lives, but we thought, even our docs thought, we got to get this antitoxin in these patients right away. We put our regional ventilator cache on standby as well. That evening, we held 3 conference calls with our hospitals, CDC, ODH, and local public health, and Kara and I were on those calls. We talked about public information and how that was going to go, who was going to be in charge of it. We talked about updated patient counts, and like I said, the counts changed multiple times during that 1-hour phone call. They just kept going up. ODH wanted twice daily patient counts, so we did that from the Hill, and we reported those on to ODH. At that point, we thought that the antitoxin would arrive into Ohio at about midnight, and State Patrol took on that responsibility of delivering those first doses to the hospitals that already had patients. Day 2, we again did bed counts. We held another conference call, and this was in 2015, so this was right at the end of the Ebola stuff. So we were doing our Ebola plans. We were meeting with our chief medical officers. We were doing all that coordination. At that point, we didn't have assessment hospitals and treatment centers. All of the big systems in Columbus wanted to be part of that process, so we were alternating hospitals. So we put that in place. We met with our CMOs, which we don't usually do, and they all said, well, let's start sharing these patients. Let's put this plan that we've done for Ebola in place for this and start sharing these patients. Let's not overwhelm one hospital. So they really started using that plan that we put in place for Ebola. We developed a specific criteria for ICU beds because an ICU bed at our critical access hospitals is not the same level of an ICU bed at our tertiary care hospitals. So there were specific things that our infectious disease docs felt needed to be in place for those. So we did type an ICU bed. It needed to be ventilator capacity. They needed to have neuro and infectious disease 24/7, respiratory therapy, and physical therapy for ventilated patients. So that took a lot of the ICU beds off the availability list, and just specific beds were available. One patient gets a second dose of antitoxin. Usually just one dose is all is given, but this patient at Mount Carmel East just was still continuing to deteriorate after that first dose, so they did get a second dose. We continued with information sharing and situational awareness, and we were checking in with Fairfield Medical Center every couple of hours. So Sunday, April 26th, what shall be known forever as the infamous CDC phone call. I got a call at 1:30, and they said, CDC wants to pull together a call at 3 o'clock with the docs that are taking care of these patients. Can you make that happen? And I said, yeah, I can make that happen. So when CDC calls at 1:30 and says, at 3 o'clock, we want to have a call, that sounds important, right, on a Sunday. That sounds like, oh, gosh, this is big. We better make this happen. So the total agenda for this call was to do education to the physicians on how to diagnose and treat botulism patients. We're 5 days into this. They've been diagnosing and treating botulism patients for 5 days. So that didn't go over really well with our physicians. So we call it the infamous CDC Sunday phone call. We managed resources with ventilators. We didn't have to activate our cache and move any of our ventilator cache. We had enough ventilators to manage the system. Beds, EMS, like I said, Fairfield Medical Center had pre-staged those EMS units. And the antitoxin, each patient had to get approval for every dose. There was just no, like Kara said, there was no pre-staging the antitoxin at the hospitals. Every patient had to be approved to get it. This is our patient tracking system, what we call OTRAC for the state of Ohio. Fairfield Medical Center, they initiated this process on day 1. So they created a huge list of every patient that came in, whether they were discharged, whether they were admitted, whether they were transferred out. So we knew where every patient ended up. So that was a huge asset for us. Final numbers, 24 confirmed cases, 11 patients were intubated, 25 doses of antitoxin were given. There was 1 death and 1 delayed death, 56 presented for assessment and evaluation. We talked about that. So the things we were thankful for, there was 1 source location. We knew the ceiling number of how many people were at the potluck. All the patients presented to Fairfield Medical Center except for 2 that were with their family members in Franklin County when they started to get sick. We're thankful that it happened in Fairfield, because if it had happened in Columbus and people had presented to 12 different hospitals and 15 different freestanding emergency departments, then would we have recognized this that quickly? Statewide coordination worked the way we thought it would. Hospital transfer centers, I told you earlier that Fairfield had to give that report every time they called. So we realized that was an untapped group in our plans. So now anytime there's a mass casualty event where they could potentially be getting patients into those transfer centers at our trauma centers, they get a page out too, so they're aware of what's going on.
There we go.
can stand over here.
What, in the middle?
Yeah, why don't you guys stand together there, and we have to stand close together so we can all be seen on YouTube. So I wanted to just follow up with one question about Aunt Millie and her potato salad.
Yeah.
So what happened there? Was whatever happened with her and what she did, other than you finding what they found in her basement? But I mean, was there anything, charges or anything like that against?
No. So the church, I will say that, again, we've said this I don't know how many times, it was a very small, close-knit community,
Yeah.
and the church rallied around her. They did not want, no one in that church wanted to press charges. No one wanted her to feel anything but welcome at the church. They did not want her to feel guilty. They knew this was not intentional. This was nothing she did with any ill intent. She did what she always does and cans her own potatoes, and this time it just happened to catch up with her. But there was no charges. There was no legal ramifications. They really rallied around her, and they supported her and welcomed her back. And they even did like a year, the church did a year anniversary of the potluck, which included a lot of different things, but also included...
I think it included pizza.
Yeah. But they wanted to make sure, there were still people who were still recovering in the long-term phases of it with the rehab and different things, but they also wanted to make sure she still felt really welcome. So they rallied around her like nobody else could have.
Gotcha. For both of you, this question, you put up lessons learned at the end, but is there anything you would have done differently?
Yes.
Okay, go ahead.
I will say that from the health department side, there was a lot, I know Jodi mentioned it, about the coordination between the hospital and the health department and the EMA. They've learned a lot of lessons from that, and they coordinate responses very, very differently now. So there was a lot of disconnect between the hospital and the health department on who was doing what. And so the hospital was doing a lot of these questionnaires. They made their own questionnaire and doing their own food history and things that the health department didn't even know was being done until much later. So some coordination more early on between the health department and the hospital would have been a little bit easier for everybody and not duplicative work.
Jodi, anything?
So there was a lot of duplicative work between the state and what we were doing as well. So the ODH asked us to get the bed counts, but then they would start calling and asking for information from the hospitals too. And the hospitals were very concerned with sharing information with people they didn't know. Even if you called and said, this is the Ohio Department of Health, well, they didn't really know if it was because they were getting media calls and they're always so truthful when the media calls. But they were concerned about that. So there was some pushback from the hospital side. So I think if we'd have mellowed that out a little earlier, that would have helped too.
So that goes into another question I had, the misinformation out there. I mean, no one knows what botulism is, and is it contagious, and oh my gosh, it's Ebola, just because you said it came after the Ebola awareness that was taking place around the world. How did you handle the misinformation? You talked a little bit about some education, but how would you do that differently, or what recommendation would you have in a crisis to get out information?
So
probably your media is your best friend there.
Right, absolutely. And from the hospital side, so we didn't do anything with that regionally, but from the local Fairfield Medical Center, they held multiple town hall meetings with the public to try to explain what had happened and that this was not contagious and there was no risk to anybody else if they hadn't been at the potluck. So they really tackled that head on from very early on.
I will also say, the rumor mill that you don't always love, that was our friend for that case as well. Information was being spread amongst the church members like wildfire. So they knew before we could even call them and say, hey, can you go to the hospital and get checked out? They knew that they were being asked to do that because they were all talking with one another. So in that sense, some of that also helped with our favor because they also were able to talk to one another and kind of share some of that information amongst themselves.
Were you able to keep it contained to that it was a homemade potato salad? I'm just kind of curious about that.
Well,
because you mentioned Kroger before. I mean, if that got out there, that would have been a whole different...
Well, we didn't know. So
Right.
It took quite a while before we got any lab samples back to confirm it. So we could only go off of our interviews and things like that and say, well, out of the 56 people we interviewed, the ones that were ill, this many had eaten a form of potato salad. So we had suspicions early on, but we did not release anything to the media on the food source for a very long time.
Gotcha. which they were probably not happy about.
Yeah, they kept asking us, and thankfully we could blame the lab, which was not in-house. It was the state lab, and we could just say, well.
Yeah, you blame the state. That's always a good thing. Does anyone have any questions? Going once, going twice. This was a great presentation. Thank you so much, and to double team it like this. Thank you very much.
Thank you very much.
Thank you. Good job.